that. And what I had as far as a potential agenda to go through then this evening is to invite Dr. Libby Stout to give a presentation on potential limits for the cannabis products, the THC limits. And so that is the subject of tonight's meeting. Allow Dr. Stout 20 to 30 minutes to present, and then have a time of questions and answers if there are, and then public comment. I believe in the past, Jason, you can correct me on this, public comment, or how have we done the public comment most recently? What seems to be the best format for that now?
So typically we've utilized the chat function and let folks enter their names in. We give them 90 seconds to comment. Sometimes we have allowed for more time just based on the number of potential commenters. But there are just a couple folks on here tonight, so I doubt that time is going to be a factor for public comment. There has been some feedback on that public comment should be taken before any votes take place, but that's up to you as work group chair.
Yeah, I think that's wise, and I think that is a better course to go. And so that was my intent this evening, is before then we vote as a work group. And basically what we would be doing as a work group is voting on a recommendation to go forth to the larger board as a potential recommendation coming out of the board. And I think that would be appropriate until after public comment has been underway. So if that is agreeable to all, if I do not hear any dissent, then I will go ahead and introduce Dr. Stout, who is an addiction psychiatrist and has been working in Colorado for a couple of decades and has been very active in understanding potential benefits and risks associated with cannabis in general. So Dr. Stout, if you would please share your screen and give us a presentation.
Paula, can you stop your screen share, please? And Dr. Berry, for your information, Dr. Eskew is on the call now also, so you do have a majority of work group members.
Oh, okay. Thank you.
Okay. I'm happy to do that, but I'm still not able to share my screen.
Are you getting some type of error message?
It says host disabled participant screen sharing.
Oh, give us just 1 second. Paula, can you undo that again?
Okay. Okay, try it now.
Okay. There we go.
Sorry about that.
No problem. That's fine. All right. Well, I'm happy to be here and present for you. As Jim said, I am a psychiatrist from Colorado, and so I'm speaking particularly about our experience in Colorado. These are my disclosures. What I want to talk about is kind of how we got where we are here in Colorado and what the consequences we are seeing from high potency THC and what we can do about it. I mean, it really kind of started, all of this started back in the 60s when they finally discovered why we like cannabis, when this lab in Israel was taking apart the different cannabinoids and injecting them into rhesus monkeys, and discovered that when they injected THC, that the monkeys became calm and sedate. And then they discovered there was a receptor in the brain that THC fit into exactly. And that's how it got called a cannabis receptor. It wasn't until the 1990s that this same lab and others around the world discovered why we have those receptors. And they discovered that we actually make our own chemicals for those receptors. And they named them, there are two that they named 2-AG and anandamide. And anandamide is a Sanskrit word for supreme joy or bliss. And what they discovered was that THC looks identical to anandamide, and so it fits perfectly in the CB1 receptor. And what we've discovered is that we have an endocannabinoid system, which is actually our mood regulating system, our homeostatic system. So it balances the excitatory and inhibitory neuronal activity in our brain. So this is a very important system, and THC can interfere with that system. And the biggest problem with that is during the development of the brain during adolescence, because these receptors play a very important role in synaptic pruning during adolescent brain development. And so THC fitting into that receptor can actually cause some problems with neurodevelopment. Now, this has been the biggest problem, is that we have dramatically changed what is considered marijuana. When we legalized medical in Colorado in 2000, the highest potency we had was 5% THC. And we only had smokable products like joints and blunts and bowls. We didn't have concentrates. Now we have all variety of concentrates that are very highly potent THC products that people end up smoking with things like a butane torch. Marijuana has been around for thousands of years, always up to the 1980s. The THC was an average less than 3%. Then, as I said, in the 2000s, it got up to 5%. And then we started seeing this dramatic increase. We started seeing the concentrates hit our market in 2010. And we now have concentrates that are well above 90%. We have some that are even 99.9% pure THC in form of distillates. And we don't have any research on this level of potency that says it's safe or effective for any medical condition. However, we have a lot of research from around the world indicating that this level of potency can be extremely dangerous in multiple ways. This is a really nice graph that I like to reference because it does explain things very well. And I am not a prohibitionist. And I agree that when you have prohibition, you have an unregulated illegal market, which increases the harms to the individual and society. When you decriminalize, you decrease those risks of harm. And when you have legalization with very strict regulations, you have the least problems. However, Colorado right now is right here, a totally unregulated legal market, which means we have had significant problems in terms of individual and society. Medical marijuana is often considered a Trojan horse because that's how the industry gets recreational marijuana into a state. They start by saying that this is, good for you. It's safe, it's pure, it's healthy, it's green. And it's important to recognize that we have had cannabis-based medications for some time. So we have a lot of FDA-approved medications that are cannabis-based or cannabinoid-based. And then we have medical cannabis that tends to be poorly regulated and poorly tested for contaminants. I am not saying that there's no benefit for medical marijuana because there is research demonstrating that. And you know that from the National Academies of Science publication in 2017. What I want to point out is that publication based most of their findings on this study. So this was a very large systematic review and meta-analysis of all the research that had been done to that date. And what they found was, and what they reported was, benefit of medicinal cannabis was all less than 10%. That's the only thing that had been studied. And we have no legitimate science at all that validates medical cannabis greater than 10% THC. In fact, there was this one study that these people wanted to find out, well, does it actually work for pain, period? And so they got healthy volunteers who would be willing to be injected with capsaicin, which is the hot stuff out of hot peppers, in their forearm. And apparently that's very painful. And if you scratch it, it's even more painful. And they found that if they gave them cigarettes with 2% THC, it provided no benefit. 4% THC actually provided significant pain relief. 8% actually caused increased pain or hyperalgesia, which is something we see with opiates. This is a cannabis researcher. So he is an anesthesiologist who studies cannabis for pain management. And even he says that the THC range supported by scientific evidence for medicinal purposes is lower than 10%. When you get higher than 10%, you get into these very risky areas. And so he says that people should be very careful about this. But what we have in Colorado, excuse me, is these products that are not medicine, but they're advertised as medicine. They're being allowed to be aggressively advertised and sold as medicine. So we have shatter, wax, which is increased adolescents using for sure. If you think about dronabinol or Marinol, this is the pharmaceutical grade marijuana product that is actually pure THC. So it's 100% THC. And its recommended maximum dose is 10 milligrams twice a day. If you buy 1 gram bag of shatter, that's 760 milligrams of THC per bag. Even with our new law, where we got a decrease in the amount that can be purchased, 18-year-olds can purchase 2 grams a day and adults 8 grams a day. That's a whopping amount of THC that is not medicine. I'm sorry. And then this guy that did the pain research, he also looked around the country at different states that are legalized. And this is Colorado. Pretty much everything that's available in either medical or recreational is greater than 15% THC, which is not supported by medical research. Europe has done this very differently, and I think that's why they don't have near the problem that we have. They've been very cautious in their medical use of cannabis. No country recommends smoking as a mode of consumption, and I understand you've got that in your law, which I support. In Europe, it is prescribed by doctors, and only if other things have been proved to not work. It's dispensed by pharmacies with prescriptions. There are no dispensaries. It's a restricted set of medical conditions, and it's very standardized. There's only one company that provides the products, and they normally range in less than 10% THC on a balance of CBD to THC. As you'll notice, they have one product that is high, but the highest is 22% THC. They don't have anything higher than that in their medical cannabis. So these are all the problems that we've been seeing. I'm not going to go over all of them, but these are markedly there. A lot of it has to do because of the increased risk of addiction. If you increase the potency of any drug, you increase the addiction potential. And we now definitely see that with cannabis. And the Dutch figured this out. They found that when the potency in their plant reached 20%, which is the average we have in Colorado right now, there was a lag time, but there was this increased need for admissions for a treatment for cannabis use disorder. This group actually came out and said that they believe anything above 15% should be considered a hard drug like cocaine, and they recommended limiting the potency to 15%. There is a definite marijuana withdrawal syndrome. In the olden days, we used to think that doesn't exist, but now with the higher potency, we absolutely see it. And I'm seeing it as something that is even worse than tobacco, in the fact that nicotine is the most addictive drug we have and the most difficult drug for people to quit because of the withdrawal. However, I'm seeing the same thing with high potency THC, that once people become addicted to THC, it's almost impossible for them to quit because of the really marked withdrawal syndrome, which is increased anger, irritability, depression, and insomnia, and they have severe cravings for marijuana. This can last up to 4 to 6 weeks after cessation because marijuana is a fat soluble substance. It sits in the body for a long time. These are studies just showing that with medical cannabis, and this makes sense because if you're using cannabis as a medicine, then you're most likely going to be using it every day, often multiple times a day, like people use other medications. And when you do that with any potentially addictive drug, you develop tolerance, which means you need a higher dose to achieve the same effect. And then you start experiencing withdrawal. And this is just showing that majority of all these people had severe withdrawal. Well, they had mild withdrawal, and 25% had severe withdrawal. And the more severe withdrawal was associating with smoking cannabis, and then greater frequency of use. Younger age, starting also predicted worst withdrawal severity, and vaping predicted significant withdrawal problems. This was just an interesting study looking at, they gave people medical marijuana cards, and they told one group that they had to wait 12 weeks before they could buy product, and the other one, they could buy product immediately. And they looked at their development of cannabis use disorder, and those that didn't have the ability to buy a product right away, clearly were getting it from somewhere because they used it occasionally, but they didn't develop cannabis use disorder. And those who got their card immediately very quickly developed cannabis use disorder. And the ones that had the highest amount of cannabis use disorder were those that were using it for depression or anxiety. And this is kind of scary. That means that 17% of these people developed cannabis use disorder within 12 weeks. And, for things like alcohol, it takes years to develop alcohol use disorder. I've experienced this in my program. I ran a program for the last 20 years. And we started seeing worse success in the program in the last 5 years with increasing potency of marijuana. And I started seeing marijuana as the primary problem and seeing a lot more significant cognitive problems, psychotic problems. And that's what I would get into now, the heightened risk for psychosis. There have been many studies now documenting this, that when people are using 15, in this study it was 15% or more, they had a 3 times increased risk of psychosis. If they were using it daily, they had a 5 times increased risk. But if they were using the stuff that was less than 5%, like the old time marijuana, there was no associated risk for psychosis. And that's why I think we haven't seen this problem until recently. That was replicated in multi-sites around Europe and in Brazil. And they found the same thing, only they found it for 10% or more. So 10% or more THC had 3 times increased risk of developing psychosis, and daily was 5 times risk. And they found that in places like Amsterdam, which had a really marked increase with daily use of THC greater than 10%, that if they didn't have that product available, they could have prevented 50% of those people with psychosis. And this is out of Denmark, just looking at a population risk, noting that if really it has to do with increased potency, they should be seeing it. And that's exactly what they found. So they looked at over 7 million individuals in the country and found that there was a significant increase, a 4-fold increase in both cannabis use disorder and schizophrenia that totally correlated with the increase in potency in THC. This has also been seen in Canada, This is before they legalized recreational, which happened in 2018. So this is just with their medical marijuana. And they found that over time, they were tripling the amounts of admissions with psychotic disorder related to cannabis. This is a study showing that, all drugs that are abused have the potential for causing psychosis. But what this study found, that the one that has the highest conversion rate to schizophrenia was marijuana. This is higher than alcohol, higher than methamphetamine. And so this is almost a 50% conversion rate, because people can get psychotic from a drug, but then they stop using it and the psychosis can go away. However, if they continue to use it, then they can get persistent psychosis, which basically turns into a diagnosis of schizophrenia. This was an interesting study just looking at the geographical range of where states that have legalized versus hospital discharges for psychosis. And they found that the hospital discharges for psychosis were higher in areas with more liberal cannabis legalization laws, meaning that they had more potent products. This is also out of Canada, just showing that over time, and so this starts with down here, the red is 2003, 2008, and then it goes up to 2013 and then 2017. As the potency increases, hospitalizations increase. And over men, it was over the lifetime. Women, it seemed to be more localized to their adolescent years. And of course, this is all causes a lot of money. This is very expensive. They also found that after they legalized recreational marijuana, they had 800% increase in cannabis poisonings in children because of the increased use of edibles. We've seen this in Colorado as well. And over time, this is just up to 2015. The concerning thing is this is adolescents attending ERs or urgent care centers. And 60% of them are requiring behavioral health evaluations. So these are kids that are psychotic, suicidal, depressed, having panic attacks. This is also related to the costs. This is hospitalizations in Colorado. So back in 2000, prior to us opening the doors for medical marijuana, it was not really talked about in emergency departments, but this was hospitalizations. And as you can see, with the increase of availability, we're having significant more hospitalizations. Then there is the association with suicide. There have been many studies reporting this correlation. This is a very large study looking at a very high odds ratio for suicide attempts. We actually see this in Colorado, that of teens who die by suicide in Colorado, marijuana is the #1 drug present in toxicology. This is much higher than alcohol, which is normally the #1 drug present. And this group came in and said that our suicide rate in teens increased dramatically. It was the highest increased risk in the country. And then if you just look at this as CDPHE data, this is over the last 5 years. With the increased potency, this is the increase in teen suicides. However, we noticed that there was a decrease in toxicology being obtained, and that was actually mandated now in our new law that they have to get toxicology to include marijuana. This isn't just adolescents, this is adults. This is in veterans, showing that over 3,000 veterans were studied looking at those who had cannabis use disorder versus those who did not. And the ones that had cannabis use disorder had much higher current suicidal ideation, much higher risk of lifetime suicide attempts. And this study controlled for pretty much everything that can contribute to suicide. Then we have this other problem, which is pretty significant. And this is directly related to the higher potency, which is this cannabinoid hyperemesis syndrome. This is an idiosyncratic reaction to marijuana that's not supposed to be happening because marijuana is supposed to help with nausea and vomiting. But this is something that has always been reported in the literature, but it was extremely rare. Now it is no longer rare, and we do believe it is because of the higher potency increasing the risk of addiction so that people are using much more frequently. So this is really only happening in people that are using very regularly. But they develop severe abdominal pain and inability to control vomiting. So they come into an emergency room screaming and vomiting, and that's been coined scromiting because it is so very detectable. And medications are very difficult to control. The normal things we use for nausea and vomiting don't work. People are having to get haloperidol to control the nausea, which is a very potent antipsychotic. And they're getting full medical workups trying to figure out what's causing it, because of course nobody can believe it's just marijuana. But there's so much research now out there showing that the only solution for these people is to quit using marijuana, and they cannot go back to using it again. There are Facebook groups that are very great in this that I direct patients toward, because they're very supportive of each other, trying to understand what's happening to them. And then marijuana has not decreased the opiate overdose death at all, no matter what the industry wants to say. And I know that your state has suffered severely from the opiate epidemic. This is our Colorado data. And if you go back to 2000, when we legalized medical marijuana, this was the overdose rates for all of these drugs. Yes, we definitely had the problem with prescription opiates, and we know all about that. Marijuana was basically commercialized in 2009 in Colorado. That was because of the Ogden Memorandum that said the government would not prosecute anybody from a state that had a medical marijuana law as long as they were following the law. So in 2009, we had 5,000 people on the medical marijuana registry. By 2011, we had 119,000. So people flocked to get their medical cards. And this is also the time when the concentrates hit the market. So we had much higher potency products showing up. And then in 2012, we legalized recreational. The stores opened in 2014. And that's when the opiate overdose deaths took off. All the overdose deaths took off. And so we've had this massive increase in prescription overdose deaths, and especially fentanyl. And there are many researchers now showing that the number one risk factor for developing opiate use disorder is using marijuana before the age of 18. The industry likes to point out this first study that was done back in 2014. This is the very first study that came out. It was looking at the states with medical cannabis laws that had a lower than expected mortality rate. And so they were looking at people between 1999 and 2010. And as I said, we didn't get concentrates in our market until 2010. And what they found was that there was a significant reduction in deaths in this population. Now, it's important to recognize this is a Medicare population, so this was an older group of people. However, they came out and said this is proof that expanding cannabis laws would reverse the opiate epidemic. Now, the industry will not talk about this next study that was put out in 2019. This group went in and did the exact same study that this group did and looked at the exact same people, but they expanded the analysis through 2017. And they included all the other states that had now enacted medical marijuana laws. And the initial findings did not hold over. And they, in fact, found that the states with medical cannabis laws had a 23% increase in opiate overdose deaths. So that means that those states that had a significant reduction had almost like a 50% increase in overdose deaths. And then there's this new paper, very new, that basically saying a key finding is that legalization of medical marijuana and its sale through retail dispensaries is associated with higher opiate death rates. So basically, what can we do about this? All we can really do is educate, educate, educate. I think we need to have PSAs about the risks, and we need to enact legislation for stricter regulations. And I would love to see a potency cap. We tried that in Colorado, and the industry fought it tooth and nail. We need to collect better data, basically, especially about the potency of the products that are being used. And people need to be doing urine drug screens. What we did in Colorado was we did actually get this law passed last year. It passed overwhelmingly bipartisan support because there were so many family members testifying about all the bad things that had happened to their families. And we actually had legislators testifying about the bad things that had happened to their families because of high potency THC. So the main thing we were able to get was this tangible educational resource requirement. So basically, it's a handout that if you go to buy concentrates at the dispensary, you have to receive this 4-page handout that has the warnings about what may cause, what may happen to you. And these are the warnings that we were able to get on. We attempted to get suicide as a warning, but the industry fought that one as well. I think it should be on there because any psychiatric medication I prescribe has a black box warning about the potential of suicide. I mean, I think if we see that high correlation, we should be able to warn people about that. We also had to put on there what was a recommended serving size for a concentrate. And that was crazy. And you may think I missed something, but it's that little tiny dot after the colon. That's the serving size. And so it's on the handout. There's this little dot that you can put your piece of dab on to see just how much is considered a serving size. That's kind of crazy. And we were able to get limits on concentrates because prior to this year, people could buy 40 grams a day with their medical card. And then there was no control for looping. And so I hope that's something you look into, because what looping is, meaning you go to one dispensary and you get your quantity for the day, and then you go to the next dispensary and get your quantity, and then you go to the next dispensary. So there was no control for that. So people were buying massive quantities and then selling it. And that's how you continue to keep a black market going. I'd say gray market. Okay. I know I have limited time, so I'll stop there and I'm happy to take any questions.
Thank you very much, Dr. Stout, for being able to present this information to us this evening and your experience in Colorado, and then also just the data that exists out there today. And so how about we take any questions from the board members who would like to question Dr. Stout at this time?
I have a question, and Dr. Stout, that was informative, and it was almost predictable from what I've kind of read and what my experience has been. But I can tell you, in these meetings that we've been over the last couple of years, there's definitely another side to this. So if you had to be the devil's advocate, why in the world would you ever, on the medicinal side, why would you lobby for no limits or higher limits based on the medical evidence that we have? I mean, be the devil's advocate. How do you make that argument unless it's from a recreational point of view?
Well, exactly. The only reason to have higher limits, I mean, to have higher potency, is to get high. That's the only reason. I mean, there's no documented medical benefit. And in fact, the documentation shows that the higher potency may be less effective medically.
Okay.
If I can ask a follow-up question then on that, one of the arguments that I have heard from people who do not want to have a potency limit is cost. Is that by having a higher potency in a single product, you don't have to buy as much as that product, and so therefore it's cheaper. What are your thoughts on that?
I mean, I don't know how to respond to that. The fact that anything, anything is going to be, it's like 3-2 beer. People can actually have problems, or the alcohol-free beer that actually has some alcohol in it. I've seen people just drink more and more and more of that, and try and get a buzz from that. And so they pay a lot more money to do that. I think that it's crazy to say this based on cost. I mean, I just, I think if people want to have a cushion, I like the idea of sticking with what Europe has done. Why do they have a potency, like the highest they can purchase is 22%? I mean, I'm sure that recreational is available. It's much higher. But when you're talking about medicine, we have to treat it like medicine. I think we really have to follow the science related to what is determined to be medicine. And otherwise, you end up having all kinds of problems. And I think then you just should say, okay, well, we don't have medical at all. We just have recreational, and people can determine what they want to do with their doctor, if their doctor wants to do that.
Well, I think all of you have alluded to the fact that the medicinal has become competition for the recreational, and the recreational has become competition for the black market, and it all merges together with these higher concentrations. I think, Dr. Scout, you made a great point that these concentrations from a medicinal standpoint should be at least in that 5 to 10% range. I mean, the horse is out of the barn with regard to prohibition, and I'm no prohibitionist either. But I think you've suggested a lot of data that's relatively supportive of the need to keep these levels lower. And the industry is not interested in that. And this committee's got to probably take a stand based on some of the things you said, but some of the knowledge that we have also. I thank you.
Sure.
When you discussed the increase in medical care costs due to the negative sequelae, is it safe to assume that that increase in cost would be the same for the Medicaid population as for the privately insured? Because we have over half of our state on Medicaid. And so that cost shift will be huge in our state, and might be something that legislators might consider better if they knew that.
No, absolutely. I mean, most of the data in Colorado is coming from the Medicaid population. And yeah, that is significant. I mean, if you talk to any of the ER physicians that I work with, that's what they say. Pretty much everybody they see is on Medicaid or have no funding at all.
I also want to thank you. I think you validated what my policy has become, is that unless you're terminally ill, you shouldn't have any other psychoactive substance besides medical marijuana. So we don't give opioids to patients who decide to use medical marijuana unless they're terminally ill. And it seems consistent with opioids that individuals who are medicating neuroses, if you will, need more medication than the average person using them appropriately. Do you think that's fair?
Yeah, that's true. And I think they're pretty good studies showing that, people going to surgery have to be careful, because if they're using marijuana, and that means medical or recreational, they're requiring higher doses of anesthetic to be able to be put to sleep.
Dr. Stout, is that presentation that you made, is that proprietary, or can you share those slides with the group?
No, I'd be happy to send you the PDF of those for sure.
Oh, that'd be great. That'd be great.
I'll just send it to Jim.
Okay. And guys, the I think one of the elephant in the room is that if we were to be conservative and treat medicinal marijuana as we kind of understand it, there's no money in it. There's no money in it. There's just not enough people in the state that actually will benefit from it at the safe, what we understand to be a medicinal level. So that's really the elephant in the room. You know, there isn't any recreational state that didn't start out with in the name of we need it for medicinal use. So I think that's a battle that we've been fighting for 3 years, to be honest with you. If we take if we take the reins off, you know, then it becomes profitable because it's in the recreational realm. Now, if I'm speaking out of school, someone please correct me, but that's like the elephant in the room every meeting that we have. And it's like everyone's a little bit scared to say it, but that's the way it is, the way that I see it. Just tell me if I'm wrong.
You know, I think my 2 cents is that there seems to be a desire among many to push out the program and tout, or at least celebrate or endorse the potential financial benefits of the program. I would argue that those of us, especially who are healthcare providers and in the healthcare realm, need to do what we can to be able to always bring this body, the board, back to first, do no harm. What can we do to make sure that we have the patients and the population of West Virginians, their health, at the first and foremost of these considerations? We've made the same, we should learn from the mistakes we've made 20 plus years ago with the pharmaceutical industry and opioids. Many of us who are on this call right now have lived through this and seen the mistakes, and I see so many parallels right now with what's happening with the pharmaceutical industry. So if we could have come back and made some different decisions, we might not find ourselves in the mess that we are in West Virginia. We have that opportunity to do so now with cannabis and try not to make the same mistakes. So I completely agree with you, JJ, and that's why I think it's important for those of us who have medical backgrounds and have this knowledge regarding the potential health effects, that we go slow and we try to provide the appropriate guardrails as this product is being unleashed into the community.
Dr.
Well,
Berry,
Dr.
I think that the information we got tonight also supports your push to have the dispensed marijuana recorded in the PDMP or some other database. And then I would also say, I think that the state should look at revenue versus medical cost increases as the program matures to see if it's a net positive.
And I have a question. I think it's for Jason. This term looping, where someone is able to go to multiple dispensaries, is there anything in our current structure now, Jason, that would prevent that from happening?
Yes, sir, there is. All our dispensaries feed into the same seed to sell system. So it's virtually impossible to accomplish that. Perhaps if there's 2 dispensaries right beside each other, if they run out one door and right into the other, they might be able to make that happen, but it's highly unlikely.
So what is the reporting time frame? Is it supposed to be somewhat instant, or is it?
Yeah, so in most cases it's instant. In some cases it's every few minutes.
Okay.
But there's a very, very small window to accomplish that.
So almost like the Sudafed system, where when people purchase Sudafed at different locations, you would know.
Yeah, we would definitely know.
Do providers have access to that to see if their patients are on medical marijuana?
No, sir, they do not.
That's why I totally support you getting that on the PD&P. This is extremely frustrating. We tried to get it on the PDMP in Colorado, but that's run by the pharmacists. And since it's not a pharmacy product, they didn't want to have anything to do with it. And so we've been trying to get it somehow. And so right now I'm trying to get a new law passed that says that the medical marijuana registry has to list the name and contact information of the doctor. Right now, they consider that confidential, which doesn't make any sense at all to me. Because when I see a new patient and I'm trying to figure out why none of their medication is working, and then I find that they're on medical marijuana, high potency, and that's the reason their medication isn't working, and I want to talk to the person who recommended they use this high potent product, they can't remember the name of the doctor because they saw him one time, it was online, there was no examination done, no look at any of the medical records, no discussion with the other people working with that patient. And so it can't be done. And that is, I think, very dangerous for patient care.
I can tell you that we're on the border of Ohio, and Ohio does absolutely report it to their controlled substance monitoring program, and we can view it and we see it, and I can't imagine there's any negative from that happening.
Right.
Now, in full disclosure, I'm on the board of pharmacy here, and I do understand that we have some challenges with it being part of this process, but I definitely see the advantages of reporting it being in the close proximity that I am with Ohio.
Dr. Milton, were you going to say something?
Thanks. I think one of my biggest struggles as a full medical cannabis advisory board, and Dr. Stout alluded to it, that in 2017, the National Academy of Science, Engineering, and Medicine basically noted that possibly, or less than 10%, as she said, nausea and vomiting, neuropathic pain, I think it's muscle spasm with multiple sclerosis, and appetite stimulation were the 4 things that worked. And we have this whole list of things that now qualify you for this cannabis card. And I really am trying to justify why would we need any more than 5 or 10% THC? And I don't know whether we'll be able to sell that to the group at all. Currently, is there a limit in West Virginia? And I may be showing my ignorance. Is there a limit to the THC levels now in the dispensaries, Jason?
So there are not concentration limits. There's a limit on the amount of THC that can be purchased, but whether it's 1% concentration or 90%, there is no limit on that aspect.
So that's based on either weight or volume, not on concentration. Yeah, that's what I thought.
That's correct.
Which is problematic to me. Thanks.
Other questions from the board to Dr. Stout?
No, thank you very much.
Thank you.
Welcome.
Seeing none, I'll open it up now for a period of public comment. And Jason, I believe you said that would be enter any comments in the chat.
Yeah, so folks, if you do want to comment and you're a member of the public, enter your name in the chat box and we'll call on you one by one. So again, enter your name in the chat box, please. Okay, first we have Dr. Husted. Dr. Berry, did you want to have a time limit or not?
Yeah, I think it's appropriate to have 90 seconds.
Okay, Dr. Husted, go ahead.
Thanks a lot, Jason. I appreciate Dr. Stoy informing everybody. It seems like sometimes we, at these meetings, we just say things like opioid overdoses go down with marijuana, or make these outrageous claims like marijuana is going to cure cancer or reduce suicide rates or whatever. And I think this just speaks to the reality that the research does not bear that out, that we need to proceed with caution. We've been subjected to such terrible things with pharmaceutical companies and opioids in general. It'd be nice to really have a very good program in our state where we put up these barriers that other states have not really been able to enact because they've been so ingrained with the pharmaceutical industry. It's just been, kind of metastasized into it and really dictated where things should be instead of the science kind of leading us. So I think for me, putting a potency cap on it, that would be, we could actually, from our state, be kind of an example of the way to do this correctly, following the science rather than, again, following the industry and the whims of people that are out to make a profit on folks that are suffering. And I just don't want to see us retrace the same steps of the opioid epidemic. So I appreciate the information. Hopefully everybody's receptive to it. Thanks.
Thank you, sir. Any other public comment? Please enter your name in the chat box. Okay, Dr. Berry, I think that might be it.
Okay, so gentlemen, the recommendation that I would put forth as an endorsement to the larger board would be that the THC content of dispensed products be limited to 10% or less. Any discussion?
Milton supports that.
Second.
Okay. All in favor of that recommendation going forward, please say aye.
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 Any opposed? So it looks like that passes. And then what we will do is from our health subcommittee, say that this recommendation was endorsed and that we support that as a larger recommendation from the board.
And
Dr. Berry, I think we should also talk about us having access to the list of individuals who receive the medical marijuana so that we don't get into some kind of side effect or synergy situation should the patient decide not to tell us the truth.
So you mean in accord with previous endorsement regarding the PDMP that has already been recommended by the board? Or are you suggesting something else?
I'm suggesting if this list already exists, it should be made available to medical providers under the same rules and regulations of privacy that the PDMP offers. Because let's face it, getting the PDMP may take a while, but since this list already exists, we may be able to get that important medical information sooner.
Jason, do you have a recommendation then? Is this something that you would suggest Dr. Vaglianti bring before the largest board for us to consider and go forward with? Or do you think it's appropriate now that we vote on this while we are in this committee? I don't want to do anything out of turn.
I think you could definitely discuss and vote while the committee is in session. However, I do have some legal concerns about releasing the patient list. I think it would probably definitely take some legislative action in order to allow that to occur. As you mentioned, it's already been recommended to the legislature that medical marijuana be added to the existing reporting system, and no action was taken on that. Definitely, there would have to be some legal discussions within the Bureau for Public Health before we would be able to move forwards with that.
Okay.
Now, Jason, I have a question. And again, I don't want to show my ignorance either, but as far as the recommendation to make it part of the monitoring program, what exactly is the holdup on us acting on that?
Yep. So the full board has already made the recommendation that medical cannabis be added to that system. There have been discussions with the Board of Pharmacy, and there's legislative action needed to allow that addition to take place.
Okay.
Perhaps JJ can speak. Well, never mind. That's
Yeah.
who asked the question.
Yes.
You honestly probably know more about the subject than I do, but the Board of Pharmacy feels that there has to be legislative action in order for that change to take place. And
Okay.
again, the legislature did not take up that recommendation during the past session.
Okay. Well, I can sort of revisit that on my end and get So it's all funneled through the Board of Pharmacy and the legislature then. So I get that, and I'll get to the bottom of that and figure out if we can get that done.
Yes, sir. That system is administered by the board and implemented by the board's vendor. So the control is really on that end.
Okay, and Dr. Berry, I would make one other suggestion too. I know you have a motion that passed unanimously, and I think what we ought to do is also at our next meeting, provide the information from Dr. Stout. So, I know we get some information, some public comments and stuff. I wonder if that could be part of our materials that's presented to us before the next board, just so that if anybody questions our reasoning, we can say, hey, this is the presentation that we worked on in our work group, and here's the basis for where we came to this recommendation.
I think that's fair. And Jason, there would be no objection to that from your end, I'm assuming.
No, I can include it in the materials.
And then I could also, if somebody would like to, and from the greater board, we could always do what we did with the other issue, other topics as well, where we could always, if somebody was interested, invite Dr. Stout and anyone else who would be considered an expert in this area to discuss and present, were Dr. Stout willing, and be able to answer questions directly from others if there was an appetite for that. So, Dr. Vagliani, do you want to give us a motion right now that you want to craft to also approve?
I'm unsure, but I'm just concerned that action at the PDMP level may take some time when we already have an existing list. So I wouldn't have any difficulty saying that I move that the process be started for and proceed with all due deliberate speed for medical providers in the state of West Virginia to have access to the list of individuals who have obtained medical cannabis.
Would need a second on that.
I second that.
Milton will second or third.
Okay, so it's moved and seconded. All in, or any discussion first? I also think it's appropriate. Is there anybody who is on the call from the public who would like to make a comment about that?
Again, if you wish to comment on the news subject, just please enter your name in the chat function.
Okay, all in favor, say aye.
Aye. Aye.
Any opposed? That was everybody. So motion passes. So Jason, that'll be the second recommendation that we will be providing to the board from the health committee.
Okay, I will speak to our council about it. Again, we certainly have the information. I just have concerns about being able to release a list of patient names to unassociated physicians, but it may be possible. I don't know yet.
Understood. All right. Motion to adjourn.
Second.
First and seconded. All in favor?
Aye.
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 Aye. Everyone's in favor.
Thank
Anyone
you,
object?
everybody.
No. So thank you everyone for your time tonight. I know it's been hard getting everyone together. I really appreciate the fact that we could do this evening. And again, special thanks to Dr. Stout. Enjoy your evening.
Bye-bye.
Bye now.